just so James, I'm going to just go through the whole process. You will have received a prescription or an instruction of a left-sided mandibular resection from the angle of the mandible to the canine region. So if you can start marking up the resection onto an anterior resection between the canine and the premolar, please.
Okay, absolutely. Something right about here. Just bringing that that resection a little bit closer to the premolar to try to save that canine.
Yep. So that's the first important point for the delegates. When you're resecting, normally you will extract the tooth and then perform your resection cut. And you know, from experience, I can tell you if it's too close to the remaining tooth, that tooth invariably will become mobile and you lose it. So you need to have a good amount of bone on the distal end of the last standing tooth so that you can preserve its integrity. So that's perfect. Yep.
Okay. And then on the posterior here.
So the horizontal cut. So again, I'll make a comment on this. This is not my usual go-to osteotomy. The sawbone work that I've done, the models presented were horizontal ramus cut. I would always counsel removal of the ramus when you're having to resect any of the ramus. So either a vertical subsigmoid or an oblique going up to the coronoid sigmoid notch. But for the purposes of this simulation, we're going to stick with the simulation and the sawbone cut. So it's a horizontal cut as you've shown, James. Thank you. Yes. So that's resection.
Absolutely. So we'll go ahead and simulate those osteotomies here. And then, as I understand it, we're using the left fibula for reconstruction today. Is that correct?
Yep, that's right. So again, for the purposes of the delegates on the course, the side to use is influenced by many factors, including not only where the pedicle is going to come out, anterior or posterior, contralateral net is used in vessel depleted nets, for example, but also you want to think about the three-dimensional relationship of the soft tissue and also subtle factors like how mesial into the floor of the mouth the resection will be. So the reason we're using a left-sided fibula here is that the pedicle is going to come out the back. It's a virgin neck, but also I want the fascia and the skin to wrap around the plate and over the mandible into the neomandible covering, but not with a huge medial resection. So there's no big floor-mouth resection. And so in a thin leg, that's a nice way of wrapping the plate and the bone with the soft tissue, but you don't need a huge amount of soft tissue medially. So left side, please.
Okay. And how high up off of that lateral malleolus should I start that first cut distally?
So 7 to 8. 7 is reasonable. That's where most people will go. So if you can mark that out, please.
Absolutely. So we'll start 7 centimeters from that distal lateral malleolus, and then I'm going to line that up. Is it okay to just follow the inferior border here? Yes, please, James. Perfect. And were you envisioning 2 fibula segments, one for the inferior border and then one for that posterior ramus?
Yes, please.
Okay. So what we'll do is we'll just line that up with the buccal aspect there. I'm going to go ahead and make the first cut right about here. And then we'll go ahead and get that other segment up towards the posterior ramus. What we're also going to do here is I'm going to show a little bit of an overlap to simulate that we'll be using a closing wedge.
Okay.
Really making sure we minimize the amount of bone that I'm having to throw away in the middle there so that we can maximize your pedicle length.
Thank you.
And then I'm thinking right about here should look really good for lining up with that posterior ramus. That would involve a cut here and here. And then here's that compared to the resected anatomy in the green there.
Okay, perfect. So just another couple of points that I'd make. I think if you're the likelihood of you needing a large segment of fibula, 2-part, 3-part, means that your pedicle is shortened. If your pedicle is shortened and coming out the front, it's going to be a long way to reach the facial artery. So invariably, you will need to bring the pedicle out the back, particularly when you need long segments. I don't have a massive issue with a pedicle that's going to have to come up a short ramus, but if it's a large ramus resection, you don't want the pedicle at the back, you want the pedicle coming out the front.
Okay, perfect. And then
Thanks, James.
Absolutely. And to show the extra capabilities of the VSP software here, I can go ahead and send everything back to its original position and show that, you know, once we have started that 7 centimeters from the distal lateral malleolus, looks like we'll be using just shy of 10 centimeters to complete that reconstruction, which would leave you with about 15 centimeters of pedicle on this particular patient's fibula.
Perfect. If you can just hold that position for me for a second, James. What I routinely do with my trainees before surgery is that I get them to look at the scans, and we'll count the number of slices. You'll have a measurement of the number of slices from the very proximal tip of the head of the fibula all the way down to the furcation point, and that will give you an idea of what sort of length you'll get to your pedicle before you start surgery. And that's just getting an eye in as to how proximal your incision needs to be, how proximal your dissection has to be, so you use the full length of that perineal artery before the tibio-peroneal trunk. Super, that's perfect. So we've got plenty of length of pedicle, and can I see the mandible lined up against the fibula and rotated around so we get a context of where that sits?
Absolutely.
The long segment of the fibula in the context of the legs.
So with the legs lined up here, that puts us right about there.
Okay, super. And then that's the final decision as far as the jigs are concerned. I'm happy with the position. It's nice, nicely conforming to the original mandible from an inferior aspect as well. There are a couple of technical tricks that you can try if you wanted to dentally rehabilitate these patients. If we can just quickly demonstrate that little technique, James, and then I'm happy to proceed with this as my final plan, please. Okay. So what you can do is you can lift that anterior segment up a little bit so that it comes up to probably about 0.5 centimeter higher, that anterior segment, and that's it, perfect. A little bit probably lower than that. You don't tend to get, you know, we talk about form and function. Actually, for the plate, for the mandible to just be lifted up a little bit, it doesn't cause too much of a disfigurement if the lower border is raised a little bit. But what it does mean is that you can have a much better restorative volume in terms of your dental rehabilitation.
That would give us a segment something like right there, which is definitely much more parallel with that occlusal surface.
Yeah, okay, perfect. So I'm happy to proceed with the plan. So we need to design, if we go back to the original plan, and then if we can start to plan the design of the plate, please.
Okay, absolutely. So what we'll do here is I'm going to go ahead and bring that original plan back up, which was this one.
Thank you.
I'm going to bring this into my preparation software here really quickly, and then we'll load up that custom plating software following. Okay, so here we have the custom plating software. This is with a 2.0 millimeter profile height custom plate. Those options that we currently have available are 2.0 and a 2.8. Is the 2.0 acceptable?
It is, yep. I'm finding the 2.8 is quite thick actually, and if the resection does go down to the soft tissue subcutaneous, you're going to feel that plate. So 2.0 is perfect, thank you.
Okay, and how many screw holes would you be looking to see on that symphysis segment?
So can I have 3 on the symphysis segment, but the other, perfect. Can we see if we can get a 4th one in there, please, actually? And
Absolutely.
The rationale for the 4th one is that sometimes when there's a delay between the planning and the plate arriving in surgery, or if there's a rapidly growing tumour, you need to have in your mind a plan B in case the resection is more than you thought it's going to be. So I always have an extra screw if I can. So 4 is perfect.
Okay, and I can show here too that it looks like we've got plenty of room away from that right IA nerve.
Perfect.
So then moving along the fibula here, how many screw holes would you like to see on this left mid body? This is what 3 would look like, for example.
Yeah, 3's perfect.
Okay. And I can get 2 more on this ascending ramus. And then how many would you like to see on that left condylar segment?
So you're only on straight plates, aren't you? Is that right, James?
I'm sorry, say one more time.
Can I get an L shape? Brilliant, that's it.
Absolutely.
So that's perfect.
Okay, excellent.
And if you bring that SH12 down a little bit away from the sigmoid notch, super, that's perfect, thank you.
Mm-hmm. What I'm going to do is try and really respect the posterior border there. And then, let's see. I'm going to really quickly jump ahead here just to make sure that we're going to be able to show this here. That's just going to be with a quick change here and here. Okay.
Can I bring SH11 down a little bit as well, please, James? It's just really difficult to access that, and if I can, if I can get through with a low pre-auricular incision, that will make it a little bit easier.
Absolutely.
Perfect.
And then, would you like to see any extra strength over any of the connecting bars on this plate?
I don't think we need to. I think we can just connect that together.
Okay, sounds good. So then we'd be looking at a plate design, custom plate, something like this on the screen here.
Perfect. And can I see inferior perspective, please? What I want to try to avoid are any sharp edges to this plate. Again, there's a risk of breakdown.
Absolutely.
And that's all nice and gentle in its curvature. Perfect. Happy with that. Can I see the position of the teeth are well away from the plate? No anatomy that I'm worried about. That's perfect for plate design.
Okay, excellent. So what we would do is, at this point, we would go ahead and get the plate ready for manufacturing. And then this would be the point at which we would discuss the cutting guides.
Yeah.
So what we would do as a default is make sure to get you a reconstructed mandible model. That would be something like right here, and it would include some dimples punched into the side of the mandible there to show where those predictive holes are going to land. And then here are some examples of our different options for the osteotomy guides. So what we have here is on that top row, we would include some slots and some stainless steel inserts that you could use to follow the saw blade, or if you prefer something much more lower profile, for example, for that posterior cut there that's getting a bit high up on the ramus, we have a marking wall option as well. That is, again, as I said, much lower profile and allows for, still getting to see some guidance of the osteotomy and the predictive holes in those lower access points.
Yeah. So one of the difficulties of getting a guide up into the sigmoid notch and around the ramus and the condyle is that it's often quite tight in space. So a guiding wall for the posterior horizontal cut would be good. I don't think you need to connect the two together, as long as the anterior guide is running round to at least the midpoint of the chin, so that there's a curvature, and that curvature will help to locate it. But of course, you can also locate it by the position of the teeth as well.
Absolutely. And then in regards to the fibula osteotomy guide, we do offer different options depending on what you're expecting for the perforator location. We do have the option that is patient specific, and it would, lock you in right here to exactly where this patient's, very specific fibula curves and twists are, or we have those additional fibula cutting guide options that would relieve it a little bit more, so that were you to prefer to locate the cutting guide up and down the fibula body at all to really optimize those perforators, we can provide that for you as well.
So can you see a cross section of the patient specific versus a more generic cutting guide in terms of the superior inferior aspects of the cut. Of course, the oblique nature of the cut's the same for both guides, and that allows you to bring your neomandible together with the fibular segments. But what the more generic guide allows you to do is compensate for the perforator position, because you don't know that until you start your surgery.
Yes,
So
absolutely.
An example of a cross-section of a patient-specific guide as opposed to a more generic guide. That would be really helpful to demonstrate that.
So the more generic options for the fibula guide are up on the top there, and then it becomes more patient-specific as we go down the line.
Okay, and so that nicely demonstrates the difference between the two. With a more generic guide, because it's two-sided, you can slide that up and down the fibula much easier than one that's specific anatomically, because the fibula may well change as you move up and down the leg. Okay, brilliant. That's really helpful. So a generic guide is fine for me. Thank you.
Okay, perfect. And then the other question I would ask for the fibula guide is, would you like to see the cutting slots on the anterior or the lateral surface of the fibula?
So can I see the cutting slots in relation to the fibula on the reconstructed mandible, please, just to see where they lie?
So what that would be is, let me go ahead and bring that up here. So if I was to pull this down here and also to bring up that leg for further reference, we're looking at the posterior surface of the left leg right now.
Yeah.
So reorienting us just to make sure that we're from the lateral surface. Let's see.
Yeah, I'm happy with the lateral surface.
Okay, perfect. So what that would be then is we would see those cutting slots, you know, making sure to make those osteotomies here, here, and here. So if I was to take us home then and see what those would look like, you know, in the position that you would be using the guide in, looking from the lateral surface here, we'd be looking at cutting slots here, 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 and here.
So the rationale for using the lateral cutting guides for me is that it gives me the maximum view of the pedicle rather than abutting the posterior surface. I get a better view of the pedicle, and I'll demonstrate that in some of the videos that you see today.
And for the purpose of making sure that we locate that custom plate correctly, we do have the options of including predictive holes for that custom plate on both the mandible and fibula osteotomy guides.
Yep, if you can demonstrate that on the model, please. So the predictive holes are really useful for putting all of this together quite quickly.
Absolutely. For example, we're going to use two guides, one for each here. You know, we've got that one with the marking wall up in the back here. That would go about only as high as we need to, you know, only using as much anatomy as we need to make sure that we're locating that in the right spot. That would include a predictive hole here and here. And then up front, the one with the cutting slot reaching across that symphysis, like you mentioned, to make sure that we are, you know, registering that to the right position on the mandible. That would also include a predictive hole here and here. Okay.
Can I see an outline of what you're going to be doing for the posterior guide? I'm not so worried about the anterior guide. So where is your guide going to be sitting at the back when you design it?
So we would definitely favor our registration on the posterior ramus with the marking wall there. Totally up to personal preference, but we do have an option to reach up and attach a small hook to that sigmoid notch as well.
Yeah, so I would prefer to have the sigmoid notch hook in, please, and that gives me a 3-point localization of that posterior cut. It'll slot in quite nicely into the sigmoid notch. All of that will be exposed for plating anyway, so it's not particularly cumbersome to be able to get into the sigmoid notch.
Perfect. And then in the blue there, we would include the predictive holes, and then in 1 to 2 different positions across that guide, we would also include a set of fixation holes just to hold that guide in place while it's being used.
Perfect. That nicely demonstrates predictive holes.
Additionally, this is my personal preference too, but I like to include a model of the bone graft as well. We call this one the bone graft template, and it, you know, we like to think that it comes in handy just for checking that resection in the patient before, you know, fixating the actual flap.
Yeah, happy with that.
Okay, perfect. What else can I help you with here?
I think that's pretty much everything. So we've gone through the resection, the side, the margins, the guides, the plates designs. How quickly can you turn that around for me?
The guides, we would be looking at at least we would say a 5 business day turnaround, 5 to 6, and then with Striker's current protocols, that would be a 7 business day turnaround for the custom plate.
Perfect, super. That's exactly what I'm looking for. Thank you very much, James. That was spot on.
Absolutely. Hey, my pleasure. Anytime.
Thank you.